and that's okay. So very welcome to this Work Package 9 webinar today that is titled Applying a Behavioral Perspective in Ensuring Access to Antibiotics, an introduction. So we think that this is going to be a very interesting webinar for you. And before we start, I'm just going to show you the agenda for today. So we're just going to introduce this webinar very shortly, which I'm doing now. Then we'll hear a presentation from Karina Godoy, and afterwards we have a Q&A where both Karina Godoy and Susanne Carregård will answer your questions and discuss anything that you might want to discuss with them. Then we have another presentation with Michael Borg, and after that we have another Q&A. And we'll wrap it up with a Menti that we would be pleased if you could answer, and then any other business if you have any other questions. So just a few points before I leave the floor to Karina. So the aim of this webinar, it's really to inspire a structured way of thinking and give you a different perspective on how to approach access-related challenges, even without deep knowledge of behavioral insights. And in this webinar, you will be provided with an overview of the methodology that Karina will give you, as well as a concrete example of how it can be applied relating to access, which Michael will go through later. So we don't expect you to apply and use these behavioral insights tools yourself in Work Package 9 work, but this is kind of an inspirational session. But with that, I will leave the floor to you, Karina, and maybe you can start also by introducing yourself a little bit. Oh, you're muted.
Sorry. Thank you, and thank you for inviting us to share our experiences on behavioral insight. My name is Karina Godoy, and I work at the Public Health Agency of Sweden at the unit of public health systems, and I have a background as a microbiologist and public health scientist. I'm also involved in the work in JAMRAI Work Package 7.4 that Michael is leading on behavior change and IPC. And me and Susanne Carregård, my colleagues, we have been working with implementing and introducing behavioral insights across the agency for a couple of years now, which is a big challenge. So we'll share my presentation. Just tell me if everything is working. So is that working now? Do you see my first slide?
Yes, it looks very good.
Yes. So today, as you said, Sophia, we have a general introduction of behavioral insights. It's more of a inspiration and how you can work in a systematic way. And I will present a little bit of the COMBI model and behavior change wheel. Also a WHO guide that we are using and implementing at the agency in Sweden, the THP guide, and then we go for questions and discussions. And please don't be afraid and don't hesitate to ask anything you have. Any type of questions are welcome. So just to set the scene, we are not working with the behavioral science in terms of producing or in relation to new theories or to understand behavior from a very, very academic way. We do work very much with applied behavioral science. So we work with it in a very pragmatic way. And Michael Hartsworth, one of the leaders, investigators in the applied behavioral science, defined it as the behavioral science as the application of findings from behavioral science to analyze and address practical issues in real world and real setting, and often coupled to a rigorous evaluation of the effect. So it is very much of an approach, but also systematic way of working with it. And you can use behavioral science in any type of issue or problem or challenge that you want to, where you want to make any type of change. So behavioral insights involves, as I said, very systematically way of exploring not just the individual factors, but also the contextual factors of the problems. And all the insights you gain, you use them to develop, to pilot, to design interventions, and implement policies, improve services and communication in well-being and reduce equity. So it's very much about understanding what is behind a behavior, why do people do what they do, and how can we support people in doing new actions if that's what we want. And I would like to say that this presentation might seem to be focused on the individuals, but it really, I mean, this is something that you can apply to any type of changing at the organization level, at the system levels, in general. So our experience from Sweden is that when we work with behavioral insight, it helps us to understand the aim of the projects, aim of the assignments, and especially if we are working in a broad collaboration. So very much to identify the concrete problem we want to change. And it offers a very clear process to prioritize the relevant groups, because you always most often have a long list of target groups that you want to target. It helps to identify and prioritize relevant behaviors to address, and also to lead you into an intervention or any type of action. And at the bottom of all the work is the COM-B model and behavior change wheel. And this gives a holistic perspective, and at least when you are working in a broad collaboration. So the challenges, I think these challenges are general for any type of issue or topic or problem you have, is that we are very much thinking of solution, and we want to jump into action and intervention very quick. And it means that we quite often jump over the behavioral analysis of the diagnosis. And when you put time initially in a project to understand what's behind and really define the problem and really define the target group and the behavior, it helps you later on to identify intervention and actions. So with that said, there is even a principle or a term that was coined by Professor Marty Eccles Islaget. You might know about it. And it said it seemed like a good idea at the moment, at the time, which is, I think we've been working a lot in that way for many, many years. So we need to be more systematic in our work. So the COM-B model and the behavior change wheel was developed in 2011 by Susan Mickey and her colleagues, and it's important to know that there are lots of different type of frameworks and models when it comes to behavior change, but none of them is complete. So they review 19 different type of behavioral change and took this COM-B model and behavior change wheel as a comprehensive way. I mean, they probably took the best thing of the the frameworks that we're studying. And this really acknowledged that the behavior is affected by a range of not just individual, but also contextual issues. So it's always taking the contextual part of the problem. And you can use it not just when you want to develop a new intervention. It can also be used when you are already doing an intervention and want to change it, to improve it, to adapt it, or just choosing between different types of interventions. So it's a quite flexible framework, even if it seems to be complex at the beginning. So at the core of the change wheel, there is the COMPI model that is identifying the different type of components that affect the behavior. In the next part, the red circle of the behavior change wheel, there are different type of functions, different type of categories and strategies that you can use to bring a behavior change. And the last part is about policy categories that can support your intervention. So the complete wheel provides you a systematic way of identifying relevant intervention functions at different levels. So, and as I say, in the core of the wheel, we have the COMBI model. There are three necessary components for any behavior to take place. So if you want to have a behavior to take place, you need to have capability to do that. You need to have motivation to do that, and you need the opportunities. And this can be divided in the capability, motivation, opportunity, in psychological capability, physical capability, reflecting and automatic motivation, and physical or social opportunity. So when we start thinking about a problem, we often think of, we need to do any type related to communication, information, education, more training. But if you think where the components, if you think of the upper part of the red part of knowledge, for example, if you want to increase knowledge by more training or education, you are actually addressing the capability. But the problem can be connected to opportunities, I mean, physical opportunities or social norms, the time, the location, the services in place, or motivation. So you need to address all three components in order to have any type of behavior change. So that's enough about the theory behind. Now the process. We've been working with, we have a collaboration for a long time with the WHO Europe. We started for about 10 years ago in a collaboration regarding vaccine hesitancy. And they have published and produced several guides, specifically, for example, for vaccine, but also for AMR. And recently, I think it was for 2 years ago, they released the THP guide, which it's more of a generic guide to tailoring a health program. So it can actually be applied to any type of topic. It's not topic specific, but it's in general within public health topics or issues. And it comprises a guide, a step-by-step process with 4 phases, and all the phases have several steps. And in the ground, there is a COMBI and behavior change wheel, but they have a slightly adapted form of the COMBI and behavior change wheel. There is also, it's included a theory of change model in it, and a very good tool book with lots of exercise, boxes of exploration, templates, how you put together your research team, what type of question do you need to do, how. So it's a lot of practical issues and ideas on how to take the work in a process, in a very structured process. And in this case, there are 4 phases in the guide, but often we use, and many frameworks are using 5. So the last phase, the implementation evaluation, can be either 1 or 2, depending on what framework you use. But otherwise, the first phase, first situation analysis phase, is to define the problem and define it in a behavioral format. You need to review your existing data, what you know about the problem, the knowledge about the target groups and the behaviors addressing the problem, but also to engage the stakeholders at a very early time, at an initial time. So once you come to the intervention phase, the stakeholders are already there. And this is something we often do, or we miss, that we involve the stakeholders a little bit too late, but they need to own their own process for behavior change. So the first time is to define, is the problem of is it a behavior? And in that case, what type of behavior? The next part, you need to find out what are the drivers and what are the barriers of the behavior, to do more research to fit the knowledge gaps, depending on what group you choose initially, but also to prioritize. It's very, very important to do prioritization all the way across the process. And the third phase is to translate the outcomes into an intervention, start planning for the implementation evaluation, and the last part, to roll out, test the intervention, and do improvement before you do a follow-up and a long-term evaluation. So a very first step when you are developing a behavior change intervention is to understand who needs to do what, when, and for how long in order to achieve your objectives. I mean, to decide on the target behaviors and decide on the target groups. And that you can do using, I mean, a wide range of information sources depending on your topic. So it could be surveillance data, scientific studies, report, previous interventions, evaluation, what type of strategies you have, action plans, anything that is important adding to your problem and your topic. So it might seem easy to decide what a behavior is. And generally, just to say that a behavior needs to be something that you can observe. It's possible to hear, possible to see. It's something that you can measure, and it is a response to something from an event from the outside. So it's responding to something. And this is more or less a verb. I mean, something that you do. If you are planning to walk, it's not a behavior because you're thinking of walking. But if you do walk, then it's a behavior. And I say it's not always easy to decide to differentiate between behavior, that is something you do, you observe, you measure, you can change, and influence factors behind. It could be attitudes, it could be emotions, it could be norms, sources, structures, systems, organization, and everything, and the outcome. So these 3 components are very important to be clear at the beginning, before you start thinking of interventions. And the target behavior needs to be defined very specific, not too broad, because then you will not be able to measure any outcome or effect at the end. For example, washing hands is something very general. You need to decide who needs to do what, when, and for how long, and with whom, if necessary. So be very specific on the target behavior you want to address. And as said before, prioritize. You will probably have a long list of target groups and a long list of potential target behaviors, and think always of what is the about the impact. Do you really need to change that, and will it have any type of impact have changing the behavior? Is it possible to change the behavior? Is it likely that the change will be that the behavior will be changed? Do you have any type of spillover effect? It means that if you address a specific behavior, does it influencing, for example, positive on other behaviors, but it could be also a negative influence. And you need to measure, be able to measure. Do you have any type of measure you can do once you have rolled out the intervention or the activities? So you really need to choose and do a priority list of what you want to address. The second part is having a situation analysis, and when you have chosen a target group or a target behavior, you need to fill the knowledge gap. You need to be more, know more, and you can do it in different way, in a quantitative, using quantitative to quality method, to gain insights to the barriers and driving forces. And at the agency, we always say use the support from the research method specialists. We do have likely a very good team of research measure specialists at the agency that are expert in surveys and different type of research method, and use that if possible, if you have that in your team, so, or your agency organization. When it comes to phase 3, you need to select the barriers to address. So you have selected your target group, you have selected your behavior, and then what are the barriers? And addressing and identifying barriers, you do it by having more information about the target groups and their reality, and then prioritize again regarding the impact. Is it realistic? Is it acceptable? Is it doable within your project? Because sometimes you can identify lots of barriers and behaviors to change, but it's not possible to do that within the project. So be realistic. And how urgent is it? What is the issue that is more higher, the highest priority? Once you have to do that, then you move to the intervention functions, which are different type of categories and strategies that you can use to bring about a behavior change. It's not, they are categories. It's not, they are not activities. So it's giving you a hint of, for example, if your capability, if the capability is physical, it could be addressed by training. If the capability is knowledge, it could be addressed with education or training or any type of enablement in general. So this is a way of structuring your challenges and try to identify any type of intervention functions you might choose between. And also the outer part of the wheel, policy categories. At the same time, in parallel, that you use intervention types and activities to address a specific behavior, you can always also consider what type of policy actions can support your intervention, because it can be on the level that you cannot influence immediately, but you can address and need to work on. So in general, using a behavioral approach, it gives you a good framework, a systematic way of working, but also taking in the context and the culture, and the system, the organization in general. And it helps to identify actionable barriers. It's something that you can do something about. And of course, to develop evidence-based interventions adapted to the very specific barriers. Thank you. Any questions, reflections?
Thank you so much, Carina. Oh, we have a question from Christine.
Yes, please.
Yep, thank you very much. For some reason, my camera won't start. I don't know why, but you can hear me?
Yes.
Yeah, okay. Thank you very much. Very interesting. I think for maybe the influencing factors, maybe you could add a point of saying availability of product, because I saw that you had prescribed penicillin, and we definitely need to have the penicillin available in order to prescribe it. Is this because you're working on IPC, the behavioral part of IPC, correct?
Yes.
And have you seen through that work, are there behavioral changes like using more veterinary vaccines or, excuse me, prescribing more penicillin that, we should be linked into within this work package so that we can support the behavioral change work that's going on in that work package? Thank you.
That is a very good question. We are in the Swedish part of the work package presented before. We decided to work with the long-term care facilities regarding hand hygiene. So we are not dealing so we decided to focus on that part of the problems and the issues. But of course, you can work with the prescribers, with physicians, and it might be that within the work package, maybe Michael knows more. Some of the other countries, I think it might be some of the other countries are addressing other behaviors. So it all depends on what type of area and topic you have chosen.
Okay, thank you very much. But if there are specific areas that have been chosen in that work group, then please do let us know if we can be of assistance.
Mm-hmm. Thank you.
Do we have any other questions? Otherwise, I have one. Maybe we will hear soon from Michael that will give more of a concrete example of how to apply this coupled to access to antibiotics. But I was wondering, maybe you could also share a little bit about concrete projects that you have been working on with this model.
Yes.
You mentioned this vaccine project, but it would be maybe interesting to hear a little bit how this can be, how you are working with this.
Yes, absolutely. And I can actually, I have a couple of slides that I can share.
Yes, thank you.
So this is actually the first study we did in collaboration with WHO, using the guide that it's called TIP, Tailored Immunization Programs, and we started with for many years ago. And the background was that there is a Somali community in the northern part of Stockholm with low vaccination coverage of MMR, measles, mumps, and rubella among children to Somali-speaking parents, and their fear was of autism. And the parents did ask for more information and dialogue, especially with the nurses at the health child healthcare nurses, and they felt they didn't receive or they didn't have the possibility to have a dialogue. And the nurses, in turn, needed tools to reinforce their role for better encounters with the parents. So this is we did with child in collaboration with the child health services, the agency, the Somali community, and to address the problem with low MMR. And we did several qualitative studies. We had coverage data. We involve, different partners there at different levels, but also a reference group in the community, which was very, very important for us because it could guide us. And the reference groups were of key persons in the community that were trusted by the community and knew the community. So I mentioned initially that it's important to involve the stakeholders independently of what type of intervention you would do. So it's very important to involve them early on. So we did a combi analysis of the data and decided this is the combi analysis at that time. This was the mapping looked like on the Somali parents, but you can do a mapping on every target group you have. So this is on the parents. You could do a mapping of the, in this case, child health care nurses and the peers also, the local community, to identify. And the green parts, the green boxes are drivers. And the red are barriers. And the interventions types were different type of dialogues, seminars about vaccination and autism, both in Swedish and Somali. We produced a couple of films about vaccine in general, with role models and storytelling. And the local peers was a very, very important group because there were key persons in the community, and they were outreaching. So we trained them in general vaccine, and we trained them in communication also. And they were reaching arenas and sites that the nurses, the childcare nurses, couldn't reach by themselves. So there was a multi-component intervention with different type of activities, and the evaluation. It's actually still ongoing because we wanted to wait a couple of years to see if the coverage has increased. And we could see that a couple of years after the coverage increased to 82% of the MMR coverage, but there have been many other influence factors in this also. But initially, we thought we would focus the intervention on the parents, but decided on the way, advised by the reference group, to also reinforce the nurses in their role, so they can have higher confidence to have a dialogue with the parents, to discuss autism, to discuss vaccine issues. So to have a general encounter for parents, because in Sweden the childhood nurses are really important for, and we think that's their role and their work and their function is probably one of the reasons of the high vaccination coverage. And they are very trusted source for the parents. But in this specific topic, like vaccination and autism, they couldn't really meet each other. So that was the first work we did, and now we are continuing with other topics and in other areas. Susanne, I don't know if you want to add something.
No, I think you covered it very well. We can say that we have been trying to apply this method in all public health areas in Sweden, but we're still working. It's still a work in progress at the agency in Sweden as well.
Thank you so much. Do we have any other questions at this point? Otherwise, I think we can move on, and you have the chance to ask Carina and Susanne questions later as well. So then we move on to you, Michael, and maybe you want to start. Most people here know you, but maybe you can say a few words about yourself before you start your presentation as well. So the floor is yours.
Okay. Are you seeing the screen, Sophia? The slides?
Yes, it looks really good.
Yeah. Okay. Perfect. So, good morning, everyone. For those of you who do not know me, my name is Michael Borge. I am the chair of the National AMR Committee. I'm also the lead for infection prevention and antibiotic stewardship at Mater Dei Hospital, which is the main hospital in Malta. And it is a pleasure for me to, again, be part of this excellent Work Package 9 initiative. And in fact, some of you, if you're regulars in these podcasts, will remember that actually exactly a year today. I don't know what Sophia has with me and February 13th, especially Friday the 13th. I hope she doesn't associate me with Jason from the movie, but it seems I get the 13th February slots every year. And in that webinar, I had gone through some of the challenges and the concepts that we have in Malta to actually improve narrow spectrum antibiotic use. And I won't repeat what I said then, but this is probably going to be a sort of follow-up to that. And just for those of you who are not here, I described the Maltese system, which is pretty unique. I don't think there are many like it in Europe for whatever reason. So I have this hybrid system that includes both free to access government health centers with resident doctors, but at least in terms of antibiotic prescribing, most of the prescribing originates from private GPs who typically work on their own. They are fully private, paid directly by the clients in terms of consultation fee. And also, when they prescribe antibiotics, these would typically, except for a very small group of income limited population, they are typically bought out of pocket at private pharmacies. And historically, Malta has always been, I always say, either the Dispois or the Dipois of the Eurovision or Euro antibiotic broad spectrum competition. So we have had this year after year looking at ESACnet data. You know, our broad to narrow spectrum ratio has always been well above the EU median. And it's something that we have looked at, and I discussed it last year. And one of the issues that we immediately encountered was that, well, one of the reasons simply was an access issue. So narrow spectrum antibiotics were and still remain to this day with limited availability in the country. And the first knee-jerk is, well, it's because the wholesalers who import antibiotics into Malta do not bring or do not bring in these narrow spectrum formulations and focus mainly on the broader spectrum antibiotics. But we realized it was a bit more complex than that. So, you look at pharmacies, and not surprisingly, pharmacies do not stock. So you have a chicken and egg scenario. And we did a survey recently, and most of the antibiotics that we recommend in our national guidelines, especially in terms of pediatric formulations and suspensions, are not available. Pharmacies do not stock them. But when we ask them, yes, it is an issue of wholesaler availability or supply, but they tell you, well, one of the reasons and one of the major reasons is that doctors do not prescribe these narrow spectrum formulations, even for those which are available in our pharmacies. So we end up ordering things like amoxicillin tablets, amoxicillin suspension, and the doctors in our area do not prescribe them. They end up on our shelves, expired. We cannot get a refund for them, and therefore we decide not to stock them again in the future. So this is an issue. And of course, this is a behavior. The prescribing of narrow spectrum antibiotics is a behavior, and therefore, to follow on from what Karina excellently highlighted, it is something that we can address by the COM-B model. Okay? And there will be a bit of repetition with obvious reason, and I don't think it's too bad, because maybe for many of you, these are still newer concepts. So it makes a lot of sense to repeat and to highlight and to re-emphasize. And I would just add that I do not expect anyone to become a behavioral scientist in 20 minutes, but at least this will give you, both my presentation and Karina's, a sort of a taste of what you can then read even further. So as Karina mentioned, the first step in the behavior change journey is to actually identify the target behavior. And this is what we have done in this case. So in COM-B, the definition of the target behavior needs to be really specific. So it's not, well, prescribing of broad spectrum antibiotics. No, that's not the behavior. The behavior is basically and very specifically that when adults present with uncomplicated respiratory tract infections, which are likely to be bacterial in origin, the behavior we would like is that the GP will prescribe a guideline recommended narrow spectrum first line antibiotic instead of a broad spectrum agent. So as you can see, just like when we do epidemiology and outbreaks, we are very specific on the definition of what the case is. In here, there are very specific pointers. It's adults who need to have uncomplicated respiratory tract infections where an antibiotic is needed, and in this case, the GP needs to prescribe or should prescribe a narrow spectrum agent. So 5 key points, and this is where the focus is. So we're not focusing on hospitals, we're not focusing on viral infections, we're not focusing on complicated respiratory tract infections. So once you have defined your target behavior, the next step is to understand the behavior in COM-B. And Karina has already alluded to this. It's basically looking at the 3 concepts of COM-B: capability, opportunity, and motivation. And each of these are then subdivided into 2 categories. So capability, the ability to do the behavior, is driven by both the physical strength, stamina, and skills to do it, which very often in stewardship and IPC are not all that relevant, and you typically rarely see physical capability coming up in these analyses. But psychological capability, knowledge, understanding, mental skills are critical. And then you have opportunity, which is all about the system. So does the system provide the physical tools, whether it is time, resources, the environment where the behavior is done, and also social? Is there a culture? Is there a norm for this behavior to happen? And is there leadership that makes this behavior the default? And then finally, as in any other behaviors that we do, there needs to be an element of motivation. And in terms of motivation, the COMBI looks at two, again, components: the reflective motivation, which are the conscious goals, the beliefs, the thought processes that we go through, the prioritization, whether this behavior is more important than others, because more often than not, there is some form of a choice to be made. And then you have the automatic behavior, which is all about habits, emotions, impulses that drive this behavior without conscious thoughts. So this is something that we had addressed and adopted for the behavior that we chose, the narrow spectrum prescribing by GPs. And we identified, not surprisingly, a number of barriers. The first being that I already mentioned, there is a lack of narrow spectrum products available in the country, which is a physical opportunity. And as a result, GPs are apprehensive that if they prescribe these narrow spectrum antibiotics, then the client will go to the pharmacy, will not find those antibiotics, and basically the doctor will come up, like an idiot. Why the hell did he prescribe this for me if he knew that it's not going to be available? And of course, with the background that I said of payment for service, this is a pretty strong driver. We also identified that many of these doctors, these private doctors especially, but even health center doctors, are relatively overworked. They're very visible, they're very accessible, and more often than not dealing with patients who believe that they should have a strong antibiotic. We are Mediterraneans over here, so we need something strong to drive us. And again, this is a combination of physical opportunity, the pressure, the time, but also the reflective motivation, both of the doctor expecting these patients to have these expectations, and also on the patient. So what happens is that when rushed, these clinicians tend to be intuitive, they go on heuristic decision-making, and therefore broad spectrum becomes a one-size-fits-all. And then, as I discussed this time last year, we live in a country which is amongst the highest for uncertainty avoidance, and this is a cultural dimension that I've published about as well, and other people have too, that definitely is linked to antibiotic prescribing. And in fact, that chart that I showed you in terms of the broad spectrum use in Europe correlates exclusively with uncertainty avoidance. So broad spectrum is used to provide a safer cover, just in case. Those three words typically define uncertainty avoidance. Then we realized that there was also some incorrect knowledge and absent knowledge of what is the resistance in the community. In other words, psychological capability. So doctors were thinking that, we have lots of resistance, for example, in strep pneumonia, when in fact this is not the case. So they were prescribing the broader spectrums, the respiratory quinolones, etc. There was no trust in our national guidelines, which again is a combination of mainly reflective motivation and psychological capability. And therefore, if they don't trust what is being recommended, then they will fall back to the broad spectrum choices by default. And again, this habitual prescribing of broad spectrum antibiotics, very strong automatic motivation, it's basically what comes to mind as an automatic response if they're going to prescribe. And then finally, they also had significant uncertainties in clinical criteria, believing that, I don't know, is this a strep pyogenes or could it be another organism that requires broader spectrum of activity? So clearly a very complex set of behavioral drivers. And the next step then, as again Karina mentioned, is that once you have identified your barriers, you need to look at what types of interventions you need to do. And in terms of interventions, there are, I believe, 9 interventions. So you can use education, giving knowledge and understanding. You can use persuasion, which is different from education. Education is just knowledge provision, whereas persuasion is aimed not at knowledge, but at intention and therefore at reflective motivation. Training, again, different from education because here you're looking at building practical skills through practice, through feedback, etc. Critically, environmental restructuring. We spoke about the physical opportunity behind behaviors, and very often physical opportunities would require some form of environmental restructuring. So basically, change the context so that the easiest path would be a guideline concordant one in our case. So for example, if you have e-prescribing, then make default show the narrow spectrum alternatives first. And if they want to go to a broad spectrum, you need to make it more difficult for them to do so. That's basically environmental restructuring. Enablement is simply, it's not often simple, but it's looking to remove barriers that we mentioned and add supports beyond education and training. So for example, using decision aids. If you realize, and that's another combi model that intervention we are looking at in terms of glycopeptides here at Mater Dei, where we know that one of the main drivers is incorrect analysis or identification of penicillin allergy. So addressing penicillin allergy, making it easier for them to come to a decision whether this patient is allergic or not, will hopefully reduce the fallback on the glycopeptides. Incentivization, and there's been some really interesting work in the UK where they basically provided a financial bonus if the GPs reduce their broad spectrum proportion of antibiotics, which had a very useful and significant impact. You can have restriction in some way, like anything else in life. If you're restricted from doing something, then hopefully the behavior would be addressed. Coercion, which goes even a step further, if you do it and you continue to do it, there are consequences and accountabilities. And modeling, which basically involves using peers who are credible, who are respected, to model, to push the behavior so that others can copy it. And again, Karina showed something similar. I like this personally because I think this table, this graph shows nicely 2 things: what is most relevant and what can be supportive. And you always try to go at the strong direct influence, but it also shows many gaps. So for example, when we talk about education, as you can see, the only domains that education addresses are psychological capability and reflective motivation. It does not address, for example, automatic motivation and habit formation. So basically, this is what we've done. We've moved into looking at what possible interventions that we can do. So we've opted for a number of possible interventions. So we're going to address many of those reflective motivation stroke psychological capability barriers through things like a Moodle platform, which one of my colleagues will be working on in the next few few months. We are addressing the resistance miscalibration, their incorrect knowledge, by sending them very short quarterly updates, and we're probably going to now start to send them a single sentence email every month, just with one message. Persuasion is going to be strongly focused on, so we've already started a public campaign, not only that antibiotics are not needed for viral infections, but also highlighting the risks of broad-spectrum antibiotics. And believe me, our population knows exactly which these are. They know the augmentins, they know the zinats, and they know the other broad-spectrum antibiotics in the community. So addressing these is possibly going to be effective, hopefully. The guideline distrust, we've already discussed actually with Christine, and using JAMRAI funds, we will be on the next winter launching an academic detailing where people from JAMRAI 9 pharmacists will go to prescribers with larger practices and actually discuss with them these issues face to face, as do medical representatives. In terms of accountability, in terms of modeling, and especially in terms of environmental restructuring, for private GPs, as Karina said, we've identified whether this is feasible, and at this stage it isn't, but it is feasible in health centers. So where we actually have an electronic prescribing system, which we are going to push further, hopefully with embedded pathways, with benchmarking and feedback, also using the senior respected peers in these health centers to endorse a narrow first approach, and introducing point of care strep testing to address that uncertainty that I mentioned. But above all, and this is why it's in bold, we need to address the availability barrier, because I cannot tell GPs and we cannot tell pediatricians to prescribe amoxicillin suspension for a bacterial pharyngitis if that is not already available. So as I mentioned this time last year, we're looking at several push and pull initiatives to hopefully improve this situation. I'll conclude now. We've done a piece. Karina has mentioned a piece is basically looking at acceptability, practical effectiveness, affordability, side effects, and equity. And you're supposed to score these, and then using the score identify what is most likely to be effective. And we've done this, and as you can see, come up with a number of FP scores. But having said that, one of the lowest scores is the availability barrier, and that is something we need to address. So even if the FP score is low, but this is a crucial, fundamental physical component of your behavior, if you don't address it, you're highly unlikely to get any behavior change. So to conclude, very short presentation. I could probably stay here for a couple of hours continuing on this topic, but as you can see, very often, like most behaviors in life, this issue related to access and use and prescribing of narrow spectrum formulations in Malta is highly complex. It's multifaceted, but by using a behavioral framework, it is possible to structure it, to identify the barriers, categorize them, look at what interventions are possible, and evaluate how effective they are likely to be. And above all, as we've mentioned, the scope of the intervention will always be influenced by the environment and the background, both physical as well as cultural. I think with that, I will stop my presentation. And thank you very much for your attention.
Thank you so much, Michael. That was very interesting.